Welcome to Doctor Warrick's podcast channel. Warrick is a practicing cardiologist and author with a passion for improving care by helping patients understand their heart health through education. Warrick believes educated patients get the best health care. Discover and understand the latest approaches and technology in heart care and how this might apply to you or someone you love.
Hi, my name is Doctor Warrick Bishop and welcome to my podcast and videocast station. And today I have the chance for interview number 3 with Dr. Sandy Zalstein, who is an anaesthetist and a colleague. Welcome, Sandy. How are you?
Hello, Warrick.
Look, for anyone who may have missed the first 2 episodes, I really encourage you to go back and have a listen. In the first one, we not only talked about some of the history of anaesthesia, but we also talked about local versus general anaesthetics. And then in the next episode, or the second interview, we covered the difference between elective cases and urgent cases and those in between. And today I'd really like to talk about what patients can do in their lead up to surgery and also cover some of the issues around heart-related matters. Now, I guess one of the questions I had, Sandy, is what would your advice be to an individual patient in terms of who's coming up to surgery? Would you encourage them to seek out an anaesthetist and find someone who suits them? Or what would be your comments or thoughts or guidance around that?
So I guess I can make it easy for your patients and say that, look, almost all the time it's always sorted out for you in many respects, and there's good reasons for that. If you go to the public hospital, obviously you're not picking any of the doctors looking after you, when you turn up and there's an anaesthetist on duty and trainees at various levels, which is great, and they'll take really good care of you, as part of a big team. In the private sector, which is where I work and these days work exclusively after sort of 25 years or so of public medicine, so the way that most patients will meet their anaesthetist is because that's the anaesthetist their surgeon or proceduralist uses. And there are usually good reasons for that, because, basically the surgeons and proceduralists put together a team around them. That team includes their scrub team and where they work, which hospitals they choose, and it also includes an anaesthetist. Often they've got long professional relationships with, and the anaesthetists understand the surgeon, they understand the cases, and they understand the patient groups. And so the surgeons have their if you like, their anaesthetist who's allocated to that list or that session, and the anaesthetist will provide the patients with care. There are some exceptions to that, obviously, in the private sector, but by far and away, to be honest, you're always going to get the best result when you go to your selected surgeon or procedures for your procedure. He's got a team, and the anaesthetist is one of the people on that team, and that's usually how you'll meet.
So this is just a nosy question as much as anything, but do the anaesthetists and surgeons who work together, do they tend to have friendships outside of work? Are they close often as friends, or is it generally business related, or is it a bit of a mix?
It can be both. There's certainly, it generally works best if they've got good rapport and a good relationship, because communication is really important between them. Communication when things are going well, and sometimes patients get into trouble and we have to help them out, and it's important to good communication helps the surgeon and anaesthetist combination, if you like, keep out of trouble, but also to address any problems that come up from time to time. So good relationships go without saying. Sometimes those relationships, some surgeons, I'm really good mates with them, but we don't see each other away from work. But I've also got some surgeons that I've been really lucky to have worked with for years, and we are good friends, and our families catch up, and there's a lot of really good interpersonal stuff that goes on, and that makes for a lot of trust. Good, that really helps us, I think, get a lot of work done. It's a commitment, and in fact, it's a relationship. My wife might despair, but it's a relationship in many respects, not dissimilar to a marriage, and it lets us look after people best.
I can certainly imagine that the importance of that relationship, because the pair of you are caring for that individual patient, and they're big stakes. Something goes wrong, they're big stakes.
Well, we it's like it's almost a dare I say, and I don't want to get too misty-eyed about it, but there is a sort of sense of family about it, and I think for surgeons too, it's a really big deal for them. These are patients who come to them looking for their care, and the surgeons are, quite rightly, I think, have some say about who they have, providing the care at the other end of the table. And it's, we've both got, it's a very much a shared responsibility. I think, the takeaway message, I think, for your audience is that there is a lot of thought, and there are good reasons why these guys or these people are working together, and they're really fortunate to have these people, these doctors working together. They'll get good results as a consequence.
Yeah, good teams, good results.
Yeah, good.
One of the things that I wanted to cover was how an individual patient might make the most of their pre-surgical time and that evaluation with you. We've talked about this in the past, and one of my soapboxes is patients should always...
I reckon, I'm going to jump in here, Warrick. I'm going to say I reckon those patients should turn up with an accurate list of their medication.
So that must be a big soapbox I've got, because clearly there's room for you to stand on it as well.
Well, that's it. I'll just stand at the back, but I'm right there with you, frankly. There's nothing. It's hard. You want to do your best for patients, and someone will come up and here's what tablets do you take? Sorry, there's another on-call coming through. What tablets do you take? I take the little red one.
Yeah, exactly.
The blue one, I take a half. You take it in the morning? Do you take it? I can't help someone when they're in that zone.
So just for those listening, Sandy, just to fill in the gaps, some of these medications are critical for us to know about when someone's some of these tablets thin the blood. Some of these tablets alter blood pressure. Some of these tablets treat cardiac failure. And you can imagine, if we don't know exactly what you're on, the consequence could be disastrous.
There's a lot of potential mischief. And one of the things, whenever patients come and see me in my rooms for big operations and so forth, is one of the first things we'll do is we'll sit down, and they're actually obliged to bring in a current list of their medications, all their medications with them, so we can make a list. Because also too, it's a source of great errors. I have to chart their medications when they get admitted. We can't just be making it up. Yourself or other colleagues have gone to a lot of trouble over a long period of time to get these patients well stabilised. We don't want that to come adrift during these particularly important times. So
I'm going to emphasise and summarise this. Whatever you do, keep an up-to-date, clear list of exactly what you're taking on your person at all times.
Totally.
At all times. I had some people say, I've got the list on my fridge at home. And I said, well, it's the fridge at home in your back pocket. And it isn't. So please, particularly if you've got one of those Webster packs or one of those devices that are issued by the chemist, which allow you documentation of your medication, tear that off and put it in your wallet or your purse. It could save your life.
Oh, totally. And just to add to that, Warrick, if I may, if you slip on the wet floor at the supermarket and you get taken into hospital, you may not be in any condition to describe You may not even be able to tell us it was a blue pill. So, having a list of those medicines on you in case of emergency too, really helpful, because not all procedures, not all presentations do we have the time to, if you like, ring up someone and find out what was on the fridge at home.
Yeah, exactly. So someone who's equally passionate as me about you being responsible for your own medications. Look, so you're going to take your list of medications there, but once you're there, Sandy, what are the sort of things you'll say to patients to help them get ready for their surgery? Are there any sort of hints or tips? Because often these elective surgeries, they're not too far away. So you can't tell them to lose 10 kilos. You can't tell them to run because they might have an orthopedic procedure. But is there anything in particular you guide them through with?
So I think of first, maybe we'll put it in the category of the red flags, all right? The sort of things that make me go, hang on, there might be a reason to, stop the relentless progression towards the operation. And what are the red flags? Well, anaesthetic complications, that's an easy one. Have you had or been told you had any major anaesthetic problems? That's a good one to know. Or any difficulties. Sometimes patients come to me and one of the first things they do is they've been given a letter by a previous anaesthetist, and the anaesthetist on it is a colleague who's looked after them before, might eloquently describe some anaesthetic problem. It might be a reaction to the drugs. It might be a difficult airway. It might be a referral they made to an allergist to have a look at like I said, an allergy to one of the anaesthetic agents or a reaction. There's some very specific anaesthetic stuff that we really want to know. At the other end too, there are quality and safety issues. Then it may devolve to nothing life-threatening, but intractable nausea and vomiting. These are the sort of things anaesthetists are really concerned about, because if we don't know about it, we can't steer you away from those issues. So that's a really big red flag. If you conversely, if you've had nothing but safe, comfortable, effective anaesthetics in the past, that's a really good starting point, and it's really good to know. Other red flags, if we, there are the highest order of things, I think, with the patients that I see, and this won't apply to everyone, obviously. Diabetes. Are you on medicines that, change, that manage your blood sugars? And that's important. I'll come back to that in a sec. So maybe diabetes are important things. If you've got implanted electrical devices like pacemakers, defibrillators, or spinal cord stimulators, they're the sort of things anaesthetists really want to know about. And medications that thin your blood. That's really important. Usually surgeons pick up on this stuff pretty quickly, and they've already addressed all of that.
So I'll jump in very quickly, Sandy.
Yeah,
just for people listening, the reason why diabetes is important is your sugars may drop while you're under anaesthetic, and if no one knows, you have low sugar, and that could really cause all sorts of havoc. If you've got devices like pacemakers in the body, then the concern with that is if we're using the electrical diathermy, which are the sort of cutting and coagulating devices, the little devices we use to stop bleeding while surgery is occurring, they release an electrical impulse, and that can confuse your pacemaker, and that can cause a mischief.
Yep.
What was the last thing you said? Anticoagulants.
Blood thinners, yeah.
Blood thinners. So if you're on blood thinners and the surgeon hasn't been informed, you can imagine if he's cutting things, you'll bleed. So these are so obvious and practical, but incredibly important.
Absolutely. Thank you. Also, too, with that diabetes issue, I'm going to push, we're talking about soapboxes here. I'm going to push a couple of soapboxes of mine alongside yours. There are, I'll just put a personal perspective on it. When patients usually have in their lifetimes a number of procedures and operations, it's not uncommon. So it does make it of interest to me. This is my own personal view, but, I think when patients get started on stuff or have stuff implanted in them, I think it's pretty reasonable to say, and when you come up for surgery in the future, you need to be aware, because the surgical process usually involves not just bleeding risk, not just blood pressure. Things like fasting. There are some new diabetes medicines which can cause real mischief. Well, in general, diabetes medicines need to be changed when you're fasting. But the fasting process usually means you need to modify or stop some of those diabetes medicines to keep you healthy, well, and keep your blood sugars and other body chemistry in the safe range. Patients got to know about that. And I think it's reasonable. It's reasonable for patients to have a plan in the event they need to fast. And sometimes the patients need to say, hey, you need to know I'm on these tablets for this condition, right? Because sometimes, like I say, if they come in with an urgent problem, they haven't had time to stop the medicines and things like that. So it's really important to know about that sort of stuff. Blood thinners, as you say, are also in that category. Because sometimes, like I say, there's normally a safe period where if we stop a blood thinner, we know it's going to be out of people's system by the time they come to the surgery. But if they come in for an emergency, that may not be the issue, and there may be antidotes or other therapies that they need. So I think there are really important things. The lifetime incidence of, in the modern era, we do a lot of operating, a lot of procedures. Patients are invariably fasting for them. You've got to be ready for those challenges. And these are good things to talk about with your doctors when you're starting new treatments. It's good to get the full briefing.
Look, I'm going to jump in, and again, I'm keeping an eye to the time because, again, the time has flown past. But one of the other things you would look at, particularly for patients over a certain age, and I think your cutoffs may be 50 or 55, is you get an ECG. And I can remember a case, it was a couple of years ago, but a very well-kept man in his, I think he was mid-70s or thereabouts, coming up for an orthopedic procedure. He'd been wanting this for some time, but when he had his ECG done, it was flagged as abnormal. His heart was racing. It was running at about 150 beats a minute in a regular rapid rhythm that we call atrial flutter. The consequence was that his heart had been driven very quickly for a long period of time. And if you run the heart for too long with a funny rhythm for an extended period, the heart can stop working properly. Well, this guy actually felt not too bad. He didn't describe any symptoms, possibly because his bad hip or knee was stopping him walking, but his heart, instead of contracting and squeezing 60% of its volume with each beat, was squeezing about 20%.
Terrible.
His heart was barely moving.
Yep.
So as part of an elective surgical assessment, I saw him and obviously cancelled his procedure. We wouldn't believe how rotten he was on me because he felt fine.
Yeah.
But the consequence was we fixed up his heart, we fixed the rhythm, and 6 weeks later when we re-imaged his heart, it had gone back to completely normal.
That's lovely.
Completely normal because we'd fixed the rate and the rhythm.
I've had a very similar thing just recently.
Let me finish. So he ended up having his surgery, all went very well. He saw me some months later.
Happy?
Still cross at me for cancelling him.
Well, I've got a happy patient who turned up for her procedure, and she was in one of those irregular rhythms called atrial fibrillation, and she didn't know. And I was able, because it's a fairly benign rhythm and she was tolerating it, and in her situation, given the nature of the surgery, she actually needed to crack on, and I was able to do some things to control her heart rate a bit. But I had a big talk to her about then. That pre-op ECG was really helpful and was really good. I was able to start some treatment on a very early in conjunction with the cardiologist who I had to see her. And I had to talk to her. I said, you got to understand, if these patients, as you well know, but the audience may not, they may not notice the slow, gentle, steady decrease in their function. And I said, number one, if we get your heart beating better, you might just feel better and enjoy life better. And that might be really good. And then, there were the related issues. And I said to her, it's a benign rhythm, but I said, there's a significant stroke risk with this. And so she was very, very grateful, very, very grateful that we picked it and we started some treatment and got her under control and referred her to a very nice cardiologist who was going to sort out the rest of her heart and check it out and actually get her on some treatment to avoid, like I said, to make her feel better and avoid her having a stroke down the future. It's a good idea in my books. She was happy.
So look, we've pretty well run out of time again, Sandy, and that just is testament to how much fun it is and how quickly the time has flown. I'm going to thank you one more time for joining me today. Thank you.
Anytime, always a pleasure, Warwick.
I'm going to use the joke that I've been saving up till the last of our interviews, which is it's been an absolute gas sharing with you. Absolute gas for those listening is an anaesthetic joke. I'm going to thank those who've been listening. Thank you for your attention. I really hope you got something out of this series of interviews with Dr. Sandy Zalstein as I did. Sandy, it really has been my privilege to have you share. Thank you so much again.
Pleasure. All the best to you and your patients.
Thank you. For those who are listening, please sign up to the podcast so we can let you know on a regular basis when these are produced and released. If you have any queries or questions, drop us a note as always. And please don't die from a heart attack. Goodbye.
You have been listening to another podcast from Dr. Warrick. Visit his website at drwarrickbishop.com for the latest news on heart disease. If you love this podcast, feel free to leave us a review.